planned for you. I'm going to start with the welcome and the objectives then for the session. Then we're going to hear from Dr. Mary Miller just about NACEL. Then Heather is going to speak to us and deliver us the Northern Ireland high-level findings for 24-25. We're going to have a 5-minute comfort break then, and then we're going to move to the recommendations, and Joy Lynn is going to share those with us. Then Dr. Dan Sutter has joined us from the Northern Health and Social Care Trust, and he's going to talk to us about the front door palliative care case study and work that he's involved in there within the Northern Trust. Then we'll move to Heather Murray just for the next steps, and then Diane has agreed to do the closing remarks. So, folks, I have been given the task just to open up today's session, so I have, and I'm delighted to welcome you all this morning to the 5th round of our national audit here in Northern Ireland for NACEL. And I believe this event provides us with a really valuable opportunity really to align the work and the values of the Public Health Agency with palliative and end-of-life care and with the ongoing efforts within our palliative care and partnership programme. We are all really acutely aware of the change in demographics of our population and the significant challenges these present to our health and social care system. I think it is therefore timely that we all reflect on the care we are delivering to people at the end of life, particularly within our hospitals. The Public Health Agency are very supportive of that public health approach to palliative care and recognise that it's becoming increasingly important as we look at how we deliver our care to that increasing population. And as we move forward, I think we need to use the data from NACEL and from other sources to inform and improve the care that we are providing. Early identification of our individuals with palliative care needs remains a challenge, but I think we all know that it's essential for that that we do identify those people in order to deliver that proactive person-centred care. We all know there's a huge amount of work to do to actually improve that identification and make sure that everyone who could benefit from a palliative care approach is identified regardless of their diagnosis or their care setting. And in particular, I'm thinking of our people with our non-malignant conditions and those from our underserved communities, such as our individuals with learning disabilities, people experiencing homelessness, and members from our LGBTQ+ community, and those in our prisons, and I'm sure there is others as well. I believe collectively our shared vision is that everyone at the end of their life lives and dies with dignity, surrounded by compassion and comfort. And I know many of you are involved in that each and every day in the care that you deliver. And we all understand how profoundly important this time is, not only for that individual with their disease and condition, but also for those that matter most to them. And we're all in agreement they deserve the highest quality of care that honours their wishes, respects their beliefs, and acknowledges their life story. Equally, we must ensure that our families and carers feel supported throughout the illness of their loved one, through bereavement and beyond. And the findings from the NACEL audit offer us a really valuable insight into the experience of people and those close to them that are admitted into our hospitals for their final days of life. As you know, Northern Ireland has participated in 4 previous rounds of the NACEL audit from 2018 to 2022. In 2023, we took a short pause while the audit was being redesigned. So this is our 5th round of the audit, covering the period from the 1st of July 2024 to the 30th of June 2025. We know it was a really big ask because we were collecting and conducting that audit over a full 12-month period. But we do believe that there is benefit in doing that because we're looking at those seasonal changes, trying to see if there's trends throughout that 12-month period. Once again, I'm delighted that all 5 of our trusts in Northern Ireland took part in the audit, and I believe the data we have gathered will provide us with one of our most comprehensive pictures of end-of-life care, both locally and regionally. So it will. This is the first time that Northern Ireland has been participated in the NACEL bereavement survey, formerly known as the quality survey. And alongside the other 3 audit components, the case note review, the staff reporting measure, and the hospital site overview. And this gives us a really unique opportunity to view the findings through multiple lenses, not only assessing whether the care document in the patient records aligns with staff perceptions, but also understanding how families and loved ones experience the care provided to their loved one. In July, we heard from our Minister, Mike Nesbitt, about the plans to redesign services here in Northern Ireland, with a focus on shifting more health and social care delivery from our hospital settings into community and primary care, bringing care closer to home. Over the past number of years, we have gradually seen that shift with more people dying at home or in our care homes, and fewer in hospitals. However, the overall number of our hospital deaths remain high due to our ageing population and our increase in annual deaths. In 2024, just last year, we had 17,860 deaths in Northern Ireland, and over 8,000 of those occurred within our hospitals. And I believe this highlights the continued importance of ensuring high quality end-of-life care in our hospital settings. I also believe that education and training of our workforce is vital to deliver this care. However, our NHS benchmarking colleagues will share with us soon that the audit has shown us this year a decline in the percentage of staff receiving training compared to our previous rounds. You'll all be very aware of the work under our palliative care and partnership work plan. The plans are in place to develop an education and learning framework for palliative and end-of-life care. And education is really essential if we're to improve the skills of our workforce and the quality of care in the hospitals and across all our care settings. Additionally, this year our audit will show a reduction in the time between recognising that someone is dying and their death. And I believe this further underscores the need to enhance the knowledge and skills of our workforce to ensure that timely, compassionate and appropriate care is delivered in our hospital settings. This year in Northern Ireland, we've also seen the Health Committee's inquiry into palliative care, and we're hoping to hear the findings and the recommendations from that early December. Alongside this, work is progressing to see how we implement the Advanced Care Plan and Policy, including the Respect Form. And this, together with the broader work of the Palliative Care and Partnership Programme, will help us continue to improve the quality of end-of-life care in all care settings. It is essential that we ensure everyone receives the highest standard of care at end of life, regardless of where they're being cared for. And I think we all recognise the profound impact that end of life care has, not only on our individuals, but also on the loved ones long after that person has died. So the NACEL audit is a really important tool, a powerful tool that helps us identify those gaps in service delivery within our hospital settings. It helps us to benchmark and continuously improve our services within our hospital environments and beyond, I believe. So as we hear the findings from the latest round of the NACEL, audit, I encourage us all individually and collectively across our trust to reflect on how we can use the information that we're going to hear today to update our service improvement plans and to implement both past and emerging recommendations. So I'm going to hand over now just to Mary, and she's going to tell us a little bit more now about NACEL 24-25. Thank you.
Thank you very much, Sally. And that was I was struck by your words and the importance of what we're doing here today for the patients and those that are important to them at the bedside. So thank you very much. Good morning, everyone. Thank you for inviting me. I'm the clinical lead working with the NHS benchmarking team, thinking about the national audit of care at the end of life, focusing on dying in hospitals. Next slide, please, Heather. Thank you. Just to run through it, I mean, Sally has covered this beautifully, really, that what we're all here today to learn about and to think about is how to improve the quality of care for the patient and those important to them, as Sally put it. And not to stop there, but to think about a variation that is not explained by individualizing care. The things that Sally mentioned, the disadvantage to those who are in prison, perhaps those who are challenged by our healthcare systems, those with neurodivergence, and also those with learning disabilities. And not just to stop at recognizing unwarranted variation, but to think about what to do about those inequities. And not to stop there, but to put in place quality improvement initiatives that drive improvements in care over time. Thank you, Heather. Thank you, Sally has covered this. This is just helping with what has happened in the nations over time. Jersey joined the audit in 2024. Thank you very much for undertaking the 12-month audit. We hope to learn more as the years go by about the seasonal effects of variation in care. Thank you, Heather. So you are one of two countries internationally that look at benchmarking care at the end of life. The other is Sweden, and there are differences and pros and cons to both models. But that benchmarking allows us to think about evidence-based improvement, as Sally has just outlined for us. In terms of supporting national policy and standards, so the standards of the national audit are drawn from the NACEL standards, including their quality standards. But it is an iterative process. So the team are in contact with the developers of the NICE guidance in order to check that it is still relevant. And as Sally mentioned, the impact goes beyond the NICE standards. There's been many requests from the different commissions to provide information. And the information that you collect is one of the few exceptional data sources that palliative care owns to influence end-of-life care policy and planning. And the last box on the right, as Sally said, the national audit provides an important barometer over time, so we can track changes in the staff survey and the quality of education that staff are receiving. Really interesting to know that the time between recognition and the patient's actual death has dropped in the Northern Ireland survey. I've always been very envious of the fact that you have been the best nation at identifying this time. So I look forward to learning more about the high-level results from Heather. And Heather, final slide, please, which is just to bring up our aim, which we share, and the 10 primary drivers, and this is our driver diagram. And it is based on the one chance to get it right in terms of recognizing in order to plan and do individualized care, communicate and support that care. And each question that is part of the national audit is linked to these drivers, so we can understand and measure the things that we feel underpin our important aim. So I want to say thank you again for inviting me. thank you for joining us today, and I look forward to hearing the high-level results from Heather. Thank you, Heather.
Thank you, Mary. So yeah, I'll be going through the high-level findings that were collected throughout 2024 and 25 in Northern Ireland. And I'll just first begin with a bit of an update on the sample size, and I'll go around this clockwise here. So this year we had 17 submissions registered, and they all submitted the hospital site overview. And just to compare against 2022 or round 4, we had 20 submissions last year, in 2022, and therefore 20 hospital site overviews. Of course, data collection was open for a full year in this round of the audit, so we had a much higher number of case note reviews received, with 1,517 submitted this year. And in comparison to 2022, that was 389. So a really great increase in that number of case note reviews. Quite similar actually compared to 2022. This year we received 686 staff reported measures, and we had 685 last year, so ever so slight increase there. But that's a great audit source as well. And then, of course, as has already been mentioned, it's the first year that the bereavement survey has been collected as part of NACEL Northern Ireland. We had 4 of the 5 health and social care trusts who were able to participate, and it's really great to have this additional data source to inform the findings. And I'd just like to say thank you to everyone who contributed data to NACEL Northern Ireland this past year, and for taking the time and effort to do those case note reviews, to complete the surveys and share the bereavement surveys as well. So the NACEL Northern Ireland 24-25 report will be published later this month. And so today's event, we're just going to give you a high-level overview of the 12 key findings that have been included in the report. Of course, if you'd like more detail, please do look out for the report once it's published and have a read through those 12 key findings. So the key findings cover these areas. I won't read them all out, but just as we go through, I want to point out, so we've drafted the report and presented the infographic so that it aligns with the England, Wales and Jersey audit outputs as much as possible. And that is so that we can facilitate the comparisons. As we go through, I'll be highlighting some comparisons to England, Wales and Jersey's 2024 findings, as well as previous Northern Ireland findings. And just to note as well, so as we go through, because we've rounded to 0 decimal places, there may be instances where you see that the percentages don't quite add up to 100%, whether that's 99 or 101. That is just because of rounding. And also we've excluded not applicables from the analysis. So if you're looking at the data and improvement tool, which I hope you are, you may see some slight differences, but that is as a result of the not applicables being excluded. So I'll start with key finding 1, which relates to quality improvement plans. So we had 59% of submissions who reported that they had implemented an end-of-life care quality improvement plan in the past 3 years, and the remaining 41% were in the process of creating their QI plans. And the key finding here is that of the 59% of submissions with a QI plan already implemented, 100% had shared these with the Health and Social Care Trust, Senior Management Team or Trust Board. In England, Wales and Jersey, there is actually a higher percentage of submissions who have implemented a QI plan, with 81% having implemented a plan in the past 3 years. And of those, 75% had shared them with their ICB or health board. But obviously, as we sort of go through with those additional 41% who are currently drafting their QI plan, we hope that they'll also be sharing them with their trust, health board or senior management team. Now, onto key finding 2. So just to orientate you a little bit. So this chart is showing 2 metrics over time. So the left 3 bars are showing face-to-face availability of specialist palliative care, and the right 3 bars are relating to telephone availability of specialist palliative care support 24/7. And each bar is there. We've got one for 2021, 2022, and 2023. So all submissions have access to specialist palliative care services, which is really great. But still, there are no organisations that have access to face-to-face specialist palliative care support 8 hours a day, 7 days a week. With that said, there has been a large increase in the percentage of organisations with access to 24/7 telephone specialist palliative care support, which has risen from 30% in 2022 to 82% in the 24-25 audit, which is a really great improvement. And just for a quick comparison, in England, Wales and Jersey, 61% of submissions have 8-hour a day, 7-day a week face-to-face service, and 90% have the 24/7 telephone access. So that telephone access is really comparable now, which is great to see. Now, moving on to key finding 3, which relates to recognition of dying. Of the patients audited by the case note review, 78% were expected to die during their final admission. So those are those category 1 deaths. Of the 23% of patients whose deaths were not expected, those category 2 deaths, 86% were recognised as being sick enough to die, whilst 14% were not. In England, Wales and Jersey, 83% of deaths were expected, so that's slightly higher. And of the 17% of patients who were not expected to die, 69% were recognised as being sick enough to die. Then when we look at the median length of time between recognition of dying and death, so we're looking at the yellow bar here, which represents that time from recognition of dying to death. And this is looking at category 1 deaths only. So it has actually increased from 63 hours in 2022 to 71 hours, which is a nice improvement when we look at sort of the changes over time, but we are still yet to return to the length of time from 2021 or 2019. In 2019, the average was 89 hours. Of course, more time between recognition of dying and death means that there's more time for conversations to take place and for end-of-life care to be delivered in line with the patient's wishes. Still in Northern Ireland, the median average is higher than in England, Wales and Jersey, where the average is 56 hours. And you can also see there with that green bar that there has been a large increase in the median length of time from admission to recognition of dying. While we don't really focus on that in the report, if anyone does have any reflections on this that they'd like to share, please do feel free to put that in the chat. It would be really interesting to see if there's any sort of examples of how that may have come about. Now, looking at key finding 4, which relates to hydration options. We've got 59% of case note reviews where there was documented evidence of communication about hydration with those important to the person, or where this wasn't possible, a reason was recorded why not. So a further breakdown of that, we had 54% of case note reviews with documented evidence of communication, and then 5% there was a reason recorded why not. And some examples of what those reasons may be were that attempts to contact the nominated person were unsuccessful, or the patient didn't consent for these discussions to take place. That does mean that there were 40% that had no reason recorded why not. We do see similar findings in England, Wales and Jersey, where 52% had evidence of communication about hydration with those important, and 9% had a reason recorded why not, leaving 38% with no reason recorded. So across Northern Ireland and England, Wales and Jersey, there is still work to be done to ensure that these conversations are taking place and that this is then documented in notes as well. So now looking at key finding 5, this relates to pain relief, and it is our first bereavement survey key finding. So obviously, as we've mentioned, this is the first time it's been collected as part of NACEL Northern Ireland, so it's been really valuable insight that's informed the report throughout, but this is the first key finding that we've got. And according to the bereavement survey findings, 84% of respondents said that they strongly agreed that the patient received enough pain relief during their final admission. We then have 8% who neither agreed nor disagreed, and a further 8% who disagreed or strongly disagreed. In England, Wales and Jersey, 77% strongly agreed or agreed, 12% neither agreed nor disagreed, and 12% disagreed or strongly disagreed. So that is obviously a slightly higher percentage of bereaved people in Northern Ireland who strongly agree with this. And for the organisations that took part in the bereavement survey, we really encourage you to take a look at your results in the data and improvement tool to compare with the regional results. And there's also further details in there, such as the time series view. So you can see that by the date of death in quarters. Now looking at key findings 6, so this relates to spiritual, religious and cultural needs. And we found that spiritual, religious and cultural needs were the least assessed when compared to other needs. And an assessment of those important to the dying person's spiritual, religious and cultural needs was documented in 36% of cases, or where this wasn't possible, a reason was recorded why not. So when we compare that to the other needs presented there, 81% of of those important to the patient had their communication needs assessed or a reason recorded why not. 75% of emotional and psychological needs were assessed, and 67% of social and practical needs were assessed or a reason recorded why not. And similarly, while slightly higher in England, Wales and Jersey, 41% of case note reviews had documented evidence of an assessment of spiritual, religious or cultural needs or a reason recorded why not. So that is a pattern that we're seeing sort of across England, Wales, Jersey and Northern Ireland, that these assessments are much lower. And within the report, we find that, you know, of those needs that are assessed, a really high percentage, sort of high 90s, are then addressed and something is done about it, but there is just that lack of assessment in the first place. So there's room for improvement there as well. Now looking at care and support ratings. So the care and support provided to the dying person in Northern Ireland was rated as excellent or good by 85% of bereaved respondents, while 79% of bereaved respondents rated the care and support given to themselves and others as excellent or good. So in both cases, bereaved people rated the care delivered to the person and those important to them more highly than was rated in England, Wales and Jersey, where it's 75% and 73% respectively. So that's a really great sign, particularly as this is the first time it's been collected as part of NACEL. So a great sort of measure to get down, and hopefully it will be a really helpful measure going forward as well. And some reassurance that the overall rating of that care is being perceived as quite good. So now looking at personalised care and support planning, key finding 8. And so we found that 29% of case note reviews had evidence of personalised care and support planning or advanced care planning conversations. And when that's broken down a little further, 4% participated prior to the final admission, whilst 25% participated during. Now in 2022, 5% participated prior to admission, so very similar. but only 9% participated during, and 87% in total did not participate. So there has been quite a large improvement in the percentage of patients who participate in these conversations during their final admission, but of course there is still some room for improvement. In England, Wales and Jersey, just for some comparison, 44% of patients had evidence that they participated in advanced care planning, with 26% of patients participating during the final admission, so that's obviously a very similar percentage, but 18% participated prior to admission, so that is quite a large difference there in the participation before the final admission. And then interestingly, so as you can see in this chart here, of the patients who were reviewed by specialist palliative care, 3% participated prior, but 31% participated during, which contrasts with those patients who were not reviewed by specialist palliative care, again, with a very similar percentage participating prior, but only 12% participating during the final admission. And again, just another plug for the data and improvement tool. You can see breakdowns like this in the tool through use of the filters. So we'd really encourage people to have a nosy around the tool and get in touch with us if you've got any questions as well. Now, looking at key finding 9, this relates to individualised plans of care. And of the people expected to die, so again, we're looking at category 1 deaths only, 72% had an individualised plan of care in place. So when we compare that to 2022, 83% of patients had an individualised plan of care in place, so that has dropped. It's also lower than in England, Wales and Jersey, where 84% of people expected to die had an individualised plan of care in place. Of course, in the 24-25 audit, we collected whether individualised plans of care were documented in the notes or in a template. And that's the first time we've collected that, so it's been really interesting insight. And we found that 1% of individualised plans of care were documented in a template in Northern Ireland. And just for comparison, in England, Wales and Jersey, of the individualised plans of care that were in place, 63% were in a template and 37% were in notes. Now, looking at equitable care for key finding 10, it previously hasn't been collected where the patient's ethnicity was unknown. So while we've collected ethnicity when it was unknown, if it was left blank, it wouldn't have been included in the analysis. So this is some new insight here. 61% of case notes had the patient's ethnicity recorded. We also found that 35% of patients' ethnicity was unknown and 4% it was not stated. And in England, Wales and Jersey, 86% of patients had their ethnicity recorded. Now, of course, although Northern Ireland is not as ethnically diverse as some places in England, Wales and Jersey, it is important to ensure that ethnicity is recorded to enable further investigation into potential differences in care and to support equitable provision for all patients, especially as demographics change over time. So now on to key finding 11, which relates to end-of-life care training. And as Sally mentioned earlier, so 44% of staff respondents to the staff reported measure strongly agreed that they've completed training specific to end-of-life care in the past 3 years. But that does actually mean that we have a higher proportion of staff who disagree or strongly disagree, with 47% of respondents disagreeing with this metric. And the percentage of respondents who strongly agree or agree has reduced from 52% in 2021. And this contrasts with England, Wales and Jersey, where 62%, nearly 2/3 of staff agree that they've received this training. I've just got another chart here to sort of demonstrate that as well. So if we look at these hospital site overview findings alongside the staff reported measure findings, while we can see that all submissions reported, they have other end-of-life care training available. This chart also shows that the availability of end-of-life care training as part of induction programs, mandatory or priority training, and end-of-life care communication skills have all reduced since the audit began. And so they kind of, as Sally mentioned, they provide those lenses to understand the data in more detail when you add those results side by side. And then on to the last key finding 12, which relates to anticipatory medication. So this is specific to Northern Ireland, as we've had a NACEL recommendation in place relating to anticipatory medication since 2019. And this finding found that 96% of patients who are expected to die were prescribed anticipatory medication, which has increased since 2022, which is really great to see, as that was 90% in the last audit. And of the patients who were expected to die that had anticipatory medication prescribed, 81% had all prescribed medications individualised to their needs, and a further 15% had some of their prescribed medications individualised to their needs, which really aligns with that recommendation. So that's the 12 key findings. As I said, it's a high level overview, and there is much more detail within the report, but we're going to take a break here now and see you back at 1:45, and give you some time to get a tea or coffee and digest some of that information before we go into the recommendations and the case study. Thank you.
Joylyn, may I ask, do you want to have a minute or two for questions from the findings, or would you rather spare the time at the end of recommendations?
Yeah, we're in front of schedule, so we do have a little bit of time. I wonder, Sally, I can see Sally's nodding, so I think yeah, we could definitely take
Yeah.
we could take 15 minutes for questions, if that would be useful to everybody.
Okay. So folks, just hopefully everybody's coming back. It's hard to know with the cameras off, maybe because of recording. Maybe just give another minute.
Yeah.
But for those that are on, is there any questions? Have we any questions for Heather or Joylyn or Mary or
And nothing in the chat so far. Yeah.
and nothing in the chat either? So Emma, thank you. Go ahead.
Thank you for that overview. It's been really interesting. I suppose just one comment on the ethnicity. That's something we struggled with when we did our case note review because it wasn't actually recorded anywhere in particular on the nursing documentation or on our electronic system at the time, which was ECR when we were doing our case note reviews. So I'm just mindful that religion was recorded, but ethnicity wasn't. That unless any of the other trusts found it somewhere, but so I think that was something that would have perhaps given us a sort of
I have a feeling,
result.
Emma, potentially in Northern Ireland, we're probably not good at recording this. So we're not, and maybe that's because we didn't have a huge ethnicity, within Northern Ireland. But I think as we move forward, we need to try to capture that. And I don't know, does Encompass, is it one of the things that you have to complete in Encompass? I'm just wondering.
Sally, that's just the question. Dan put that into the chat that Epic would capture. And I was asking, is it a hard stop in Encompass or can it still be overwritten? And Donna Louise has just come back there to say we don't think it is a hard stop. So
Okay,
there's
so
obviously the functionality and the ability in there. Only time will tell whether or not that will give us better information moving forward. But it's obviously a conversation we can take back as well.
Mm-hmm.
I think this is interesting because those of you who were at the Palliative Care and Partnership Programme Board meeting yesterday, where we presented the regional self-reporting of the ambitions framework. Again, this is the area, the equitable access to care is an area which we know in Northern Ireland we're not doing as well as we should be. And I say part of it, I think, is you're right, Sally, we still, compared to other areas of the UK, have a very small there's less than 2% of our deaths every year are from anything other than white, British or Irish. But that is increasing. And even if it's 2%, we still need to be taking the cognizance of it and make sure that their needs are being appropriately addressed. So, it's something we'll Dan's saying there it's an easy audit for somebody. So if somebody wants to take that on, Dan, I think, is that a hand up? I'm not sure.
Folks, any other questions or any other comments just on the findings so far? I don't see any other hands, so maybe we'll hand back over to you, Joylyn. Oh, Emma, you've your hand up again, is it? Or yes, yeah. Emma's coming in again. Thank you.
I'm just sorry. I'm thinking about the education delivery too, and I'm thinking how that, Diane, compares to the recent scoping of education we've done throughout the localities. And I'm just interested really to find out how other areas have mandated this education, because to me, that's a huge task to be able to mandate palliative end of life care education. And I'd just be really interested how that's been done in the other areas that have scored higher than ourselves.
So anybody want to come in and maybe answer to Emma what methods you're using within your trust or organisation to mandate that education and training in relation to palliative care? everybody's gone silent, Emma. And I have a feeling that it's maybe not well mandated anywhere. So Dan, we were turned down when we asked for our part of care, and I can only see the end of that. Hold on.
Yeah.
So
Too busy.
I think there is issues. Yeah. So Dan's just in there. We were turned down when we asked for a part of care introduction to be made mandatory, scheduled too busy. And I know that was the conversation that was in the past. Whenever I was working on trust side, that it was difficult to make palliative and end of life care mandatory. However, we're able to make other things mandatory, and I'm thinking of our CPR, and yet many of us, or the majority of us, will be involved in delivering care to patients who are dying. And not so many of us will be involved in CPR. Now, I'm not saying that CPR is not important. It absolutely is. But I think, there needs to be some thought that goes into that. And maybe it needs to be done at a regional level. Dare I say it, Diana, maybe disagree with me. And I'm just wondering, is the education and learning framework going to give us an opportunity to do that? Folks, there's 3 hands up. So there's Karen, is it?
Yeah.
Or Karen?
No, it's
Karen.
Karen. No, sorry, it's a very confusing name. I think the interesting comparator would be how it's actually achieved in England and Jersey, in those localities, because they're obviously doing something better than us. And if we could understand what they're doing and how they've managed to get their, it's really quite a marked difference in the percentage between the amount of training that's been undertaken for the last 3 years in those localities compared with Northern Ireland as a whole. I think that would be very interesting to us in Northern Ireland to see what the difference is, how they're doing it differently.
Yeah, thanks, Karen. And maybe Mary's going to come in and tell us what they done elsewhere. Oh, you're in mute, Mary. Sorry.
Excuse me. And Joellen may want to add a comment, but just to say that we've also found it incredibly difficult, and it's a trust by trust basis, and trusts that have had it have changed status, so it's not been an even playing field. It doesn't mean once you've got it that it stays there. I think that I have found it really helpful to have the data improvement tool graphs in my own trust, and in my report I put it in. It doesn't solve the problems of who's going to deliver this training, etc., and how you help people stay up to date, but it does raise the profile in my trust every time. And I think that raising it at regional and national level is the way to go to. I think having this conversation in a bigger arena might help the trusts get on board. Thank you.
And I know Diane's got her hand up, but Joellen, is there something, I'm just thinking, were you going to say something in relation to what Mary has said, or do you want me to go to Diane first?
Yeah, I've just put a link in the chat, and I suppose I would encourage everybody on the call to look at our NACEL Good Practice Compendium, which has been devised for England, Wales and Jersey, where we've shipped. It includes 68 excellent examples of quality improvement work around end-of-life care and palliative care in hospitals. And it's all grouped by themes. So you could search for the word education and it will highlight different QI examples across England, Wales and Jersey. So that might be a good start. And if there's any that are really useful for you and you'd like to be put in contact with the project leads, then just drop the NACEL team an email and we'll try and facilitate that link up.
Okay, and then Diane.
Yeah, thanks, Sally. I know from the conversations I've had with others in ICBs that getting education, there's similar issues with getting education mandated and prioritised, but it obviously is happening in some trusts, so it would be interesting to see that good companion and learn from some of those. With regards to the regional education and learning framework, I mean, that is, as members will know, or as colleagues will know, that has been drafted, and within that there are very clear components around recognising dying and holistic care for patients and those important in the last days of life. One of the things I think we found most surprising when we did that large scoping of what the training is that's currently available across Northern Ireland. And remember, this is not just in our hospitals, this was across our care homes, our hospices, our community, etc. There were very, very few options around those two components. So at the minute, it is not an area that is being widely, there are parts of them within other training, but it's not being concentrated on. So we'd be very keen to see that. And say the work is progressing with that framework, but the framework will not deliver the solutions. The framework will deliver the framework of what education and learning should be available to staff in the organisations. The responsibility for delivering the education will still continue to lie with the employers to ensure that they have the staff who are competent and confident to deliver the care that's required of them in the settings that they're working in.
Thank you, folks. Any other questions that anybody wants to raise just at this point?
There's just a discussion about individualised plan of care in the chat. Just to bring your attention to that, Sally, from John, just saying, 1% in Northern Ireland compared to 63% in the wider UK sample. And Dan has commented about that to say absolutely, and anybody from DOH on the call.
I'm not sure if there's anybody.
Sorry, just to clarify, the Department of Health said we couldn't have one at a recent, as part of the recent, that palliative care review they were doing. We're working on local solutions.
Yeah. So I don't think there's anybody officially from the Department of Health on that, but I'm happy to take it as Dan says. I mean, the policy position from the department is that a regional template is not appropriate at this stage. The advice is that local as will have been the case with the 63 trusts. The trusts in England and Wales that are not all using the same template. They will be using their own specific template for their hospital trust. I'm looking to Mary. So that is the position at the minute from our Department of Health, that if it's deemed necessary to improve quality of care, local organisations should be working on developing theirs.
Thank you. And may I just have a brief word about that? That's absolutely true, Dan. And that comes back to thinking about the post-LCP world that we live in. And it is a disadvantage. And we've just started some work, as Rosie Brannert, who's not here today, one of the NACEL team, and we can clearly demonstrate that an individualised plan of care does improve care, and that it does help reduce some of the inequities that are happening. So more to come from England and Wales, but it's a big piece of work, Diane. Again, I'm just looking, there may be some examples in the Good Practice Compendium, and certainly lots of people are moving to putting some sort of hospital level individualised plan of care on their hospital systems.
Thank you, Mary. And Sarah, then just...
I suppose, hi there. Just to clarify, there will be trusts in England and Wales with the same number of patients and caring for the same population as it is in Northern Ireland. So our trusts are extremely small. So it's not an additional risk in terms of the numbers of staff, or in fact, it's a bigger risk having 5 small trusts performing 5 templates. If we're going to compare, and if that is the only argument from the Department of Health, that falls very quickly when we look at the numbers, population and staffing. The other point is it would be really useful to have a repository, an area where we can review templates that are used elsewhere, particularly those on Epic. At the moment, I'm trying to go through the process of just contacts and people I know and asking them to take screenshots. So I don't know, Mary, if there's some way of collecting that up through NACEL. In a more kind of official way to see what other templates look like, because that would be extremely helpful, as opposed to me just cold calling colleagues in other trusts.
Thank you very much for that, Sarah. May we take that away and work about it? I know that we have a little short list in our head of people who are doing the work and are perhaps more advanced than some of us, including me. So may Joelyn and I take that away and think about the how and come back to you.
That's great. Thank you, Mary. Folks, I think if if there's no more hands up, we'll hand back to Joylyn and just move on with the recommendations, because I'm just conscious of the time. We've maybe used the time that we had going spare there for a little bit. So I'll hand back over to Joylyn just to discuss the recommendations with us.
Lovely, thanks, Sally. And thank you everyone for being so engaged and contributing to the discussion, and also for all of your efforts in submitting data to the audit. We really appreciate it. So yeah, during this session, I will share the recommendations which are included in this year's State of the Nation report. So there have been 8 recommendations that have been identified as being the most important to be able to improve the quality of end-of-life care delivered to dying people and those important to them in hospitals across Northern Ireland. And all of the recommendations are born from this year's audit results, as well as a consultation between the NACEL team at NHS Benchmarking Network and the Public Health Agency. And some of the recommendations, I think you'll recognise, they've been carried over from previous audit reports, where we've made slight tweaks to make them a bit more focused based on this year's audit findings. And then we have also introduced a couple of new recommendations. But you can see on the slide here, these are the 8 themes for those recommendations. So for the first recommendation, we have updated a long-standing recommendation that's been included in the NACEL Northern Ireland report, which is always focused on access to specialist palliative care services. And where previously the focus was on ensuring that there was telephone availability 24 hours a day, 7 days a week, as we've seen, really positive improvement in the availability of these services, we've updated the recommendation to now focus on that face-to-face provision. And the recommendation reads, in collaboration with the Palliative Care in Partnership Programme, the Department of Health and Commissioners should work towards having specialist palliative care, doctor and/or nurse face-to-face availability 8 hours a day, 7 days a week. And this is supported by the NICE Quality Statement 13, which advocates the need for adults approaching the end of their life and their carers to have out-of-hours care and support at any time. And this recommendation is evidenced by key finding 2, which Heather shared, where we could see that actually at the moment there are no health and social care trusts that have face-to-face availability 8 hours a day, 7 days a week, hence the need for this first recommendation. So then moving on to recommendation 2, the focus here is on communicating hydration options. And this reads as is aimed at chief executives of health and social care trusts boards, in that they should ensure that clinical teams delivering end-of-life care communicate hydration options at the end of life with those important to the dying person, where all reviews, communication and support should be clearly documented in the patient's care records, and professional guidance from the GMC should be implemented, and the NMC's, the code, should also be adhered to. And the recommendation here is supported by key finding 4, where we saw that only 59% of case note reviews had documented evidence of communication about hydration options with friends and families, and where not this was recorded as why. Moving on to recommendation 3, the focus here is now on spiritual, religious and cultural needs. And again, this is a recommendation that we've updated from previous audit reports. And the previous recommendation here specifically was a bit more broader, and it focused on the implementation of individualised plan of care, individual care plans. And here we've now focused this to to look at spiritual, religious and cultural needs. And it reads that chief executives of health and social care trust boards should ensure that patients at the end of their life have an individualised plan of care which assesses and addresses the spiritual, religious and cultural needs of the dying person and those important to them. And this is supported by NICE Quality Standard 144, which states that care at the end of life should be responsive to the personal needs and preferences of the person who is dying. And again, the finding which contributes to this recommendation is from Key Finding 6, where we noted that 36% of case notes had an assessment of the spiritual, religious and cultural needs of those important to the dying person or a reason recorded why not, yet 64% of cases had no documented evidence of an assessment and no reason recorded. Recommendation 4 now focuses on the care and support given to families and others. And this is one of our new recommendations for NACEL Northern Ireland. And the results are strongly backed by the evidence that we've captured from the bereavement survey this year. And the recommendation reads that chief executives of health and social care trusts should ensure the needs of people important to the dying person are identified, assessed and addressed with compassion and timeliness, both during the person's final days and following death. And that trusts should assign clear senior, strategic and operational responsibility for this area of care, ensuring sufficient capability and capacity to provide meaningful support. And this responsibility must include structured assessments of emotional, practical, spiritual, religious and cultural needs so that families and others close to the patient receive holistic, effective and sensitive care, extending into bereavement support where required. And the findings that support this are Key Findings 6 and 7, as is shared on the previous slide. There's around a quarter of patient case notes where the assessment of holistic needs was missing. So that's emotional, psychological, spiritual, religious, cultural, practical needs, and communication needs. And from our bereavement survey, we saw that 14% of bereaved people rated the care and support given to themselves as fair, and 7% said that the care provided to them was poor. So this strengthens the need for this recommendation 4. Recommendation 5 then focuses on personalised care and support planning, which includes advanced care planning conversations. And this reads that chief executives of health and social care trust should work to increase the number of personalised care and support planning conversations offered to patients in the last years of life prior to their last admission to hospital. And this includes that personalised care and support planning should be reflective of the patient's choices alongside their legal, financial and personal wishes at the end of life, and a record of the offer. Any discussion and plans should be available to inpatient teams once a patient is admitted to hospital. And we know that it's not always possible to carry out advanced care planning conversations during that final admission, which is why the emphasis of this year's recommendation looks at encouraging these conversations to take place in the community prior to that last admission to hospital. And the findings that support this recommendation is that this year we reported that 29% of case notes had evidence that the patient had participated in personalised care and support planning conversations, and only 4% of these conversations took place prior to the patient's final admission. So moving on to recommendation 6. Again, this is another new recommendation for the audit, and the focus here is on delivering equitable end-of-life care. And it reads, chief executives of health and social care trusts should take responsibility for ensuring that high quality palliative and end-of-life care is delivered equitably and is responsive to the specific needs of the local population. And this includes, we've given 3 suggestions. This includes implementing robust and systematic processes to collect and record individual demographic data, with particular emphasis on the accurate documentation of ethnicity. And as the conversation, as people have alluded to today, hopefully that we'll see results start to improve over the years with the implementation of Encompass. Another example is that we've asked that proactive identification is, and that the trust address existing inequalities within the trust areas, and that training is delivered to healthcare professionals to offer an interpreter or an appropriate communication alternative to those where English is not their primary language. And you'll see once you look at the report, we've got some more results that support this recommendation. But as Heather's shown today, 39% of patients didn't have their ethnicity documented from the case note review. And from the case note review, we also showed that there were 18% of patients that were not offered an interpreter or a suitable alternative, where this was needed for communication to take place. And again, there was 38% of families and friends that again were not offered an interpreter or a suitable alternative. So that's recommendation 6. Recommendation 7 is another long-standing recommendation which focuses on training, and the focus here is on induction and mandatory priority training. And it reads, in collaboration, the Palliative Care in Partnership Programme, the Department of Health and Commissioners and Health and Social Care Trusts should work towards end-of-life care training programmes becoming embedded in induction programmes and or mandatory priority training programmes in Northern Ireland. End-of-life care training should ensure that staff have the knowledge and skills to support the patient and family, develop staff competence and confidence to recognise imminent death, communicate with the dying person and people important to them as early and sensitively as possible, and deliver end-of-life care. And again, a recap of the findings that support this recommendation can be found in key finding 11, where we saw that only 12% of hospital sites have embedded end-of-life care training within their mandatory priority programmes, and 53% of hospital sites had included end-of-life care training within their induction programme. And then the final recommendation that we want to share is recommendation 8, and this focuses on communication training. And we haven't made any changes to this recommendation, so it's still the same as the report from 2022, as it still remains highly relevant and arguably more important than ever, given that we've seen that decline in the communication skills training from 100% in 2018 to 80% in 2021 and now 47% in 2024. And this recommendation reads that chief executives of health and social care trust boards should provide training opportunities for health and care staff to improve their end-of-life care communication skills. They should support health and care staff to gain competence and confidence in communicating effectively and sensitively with patients and families in the last days and hours of life, and training for clinicians and other staff who have contact with dying people should focus on supporting the delivery of NICE guidance NG 31. So that's all 8 recommendations and the key findings that support these recommendations, and we hope that these 8 provide a clear framework for improving end-of-life care, focusing in hospitals. Just to reiterate, we really do encourage you to use the NACEL data and improvement tool to be able to identify how your hospital performs against these recommendations, and so that you can identify strengths and the priorities for improvement going forward. I think I am also a bit, we're doing good for time, but I might pass to Daniel for the case study. Maybe we might have an opportunity for question and answers at the end. So yeah, I'll hand over to Dr. Daniel Suter from the Northern Health and Social Care Trust. So thank you.
Thanks very much. Can I have control of these slides, or?
Yes, you should be able to. There might be.
Oh, sorry, take control. Here we go.
Yes, perfect.
Very good. Okay. So apologies to anybody who's already heard me talking about this. It's relatively well, it is linked to NACEL in some important ways, but I suppose it's really just to show, I guess, some tips in terms of how to get quality improvement projects surrounding kind of end-of-life care, palliative care, off the ground, and some of the ways we went about that here that may be useful to somebody out there. So we're going to talk about how we identified a problem we wanted to look into, figuring out how we were going to try and address that problem, how we got things off the ground, and who's helped support us, kind of a rough timeline of how things have unfolded since then, how we've tried to show benefit from the project, and then just a slide about challenges and kind of next steps. So I think anybody who's working kind of near close to the front line of caring for patients at the end of life will have an idea of issues where they work, or sometimes wider than that, in terms of how to provide this care for people, or where there are gaps in the service. And so local knowledge is often the first place we start to think, I wonder if there's some bit of work we could do about this. But there are other things that can be useful for identifying problems. So there are demographic facts. So here in the Northern Trust, we know we have the largest and the oldest population in Northern Ireland, so we will have increasing numbers of patients needing care in the dying phase of their life. And there also, we were able to draw on some local research that had been done relatively recently to help signpost us, I guess, to make sure we weren't barking up the wrong tree in terms of looking for areas to improve. So from this study in EDs across Northern Ireland 2015, we were able to see that lots of patients in the emergency department had unrecognised palliative care needs. We had an idea of why these patients needed to attend the emergency department, and the fact that a lot of patients had 2 or more ED attendances in the last 12 months of life. And then here more locally, we had basically found a similar finding, not surprisingly, in the emergency departments in the Northern Trust, that 21% of patients admitted in the Causeway and Antrim hospitals could have benefited from palliative care services. So a lot of this work was done before I came here, which was lovely. My colleagues, particularly Dr. McCann, Dr. McNutt, Dr. McCann's on the call, and I'm sure Sally was probably involved as well back in the day, recognized that we needed to formulate a kind of a business case for, mainly because what we were looking for was going to require funding, new money, and that won't always be the case with quality improvement project, but in this case it very much was. So we needed senior staff involved in that, and then aligning what we wanted to do with kind of local and regional strategies. So we know from the palliative care and partnership workforce planning here in Northern Ireland, there's reports a few years ago now, kind of created recommendations for kind of consultants cover. So they recommended kind of 2.88 whole-time equivalent consultants per 250,000 people. We know our population here in the Northern Trust is about 480-odd thousand. And so that sort of equates to 5.5 full-time equivalent consultants, and they were currently operating somewhere less than 3. So that was helpful in going and saying, look, I think we already knew that we needed more consultant cover, but how could we also align it with the quality improvement work we wanted to do? So we had to sell it, and what was helpful in that was aligning it with trust literature. So we're able to say that within the trust, it was a key focus that had been clearly written and documented, so we could point to it and say, well, here's your plan. How are you planning to achieve that? We think we need to do this. We also benefited, it seems strange to say, from, I guess, COVID pandemic. Palliative care was really brought to the forefront of a lot of people's thinking in hospitals and in our communities, and so that really helped, I guess, particularly at higher level management in the trust, get this on the agenda. And indeed, in England, access to palliative care has now kind of become a legal right, and hopefully that will follow here too. So what we were able to come up with, I say we, this was again before I was involved, but we were able to come up with a job plan for a temporary 2-year job with a focus on front door palliative medicine. And so it was a 10 PA consultant job, incorporating not just palliative medicine in our ED and the DAU, which is the direct assessment unit, our kind of ambulatory acute medicine unit, but also to provide a liaison consultant to do work within the Antrim Hospital site, clinical support for the team already working there, and help out with the on-calls, of course, and take on some formal education roles within the trust. I came into this job, I had worked one previous consultant job for about 6 months in the Northern Ireland Hospice, and so this was very early in my consultant career, so I needed support in this, and as well as support from my team. What I find fantastic here, and I suspect there are probably these programs in every trust in Northern Ireland, was what they call the kind of Safety Quality North program here, which is run by the QI team, and that is for any members of trust staff looking to engage in quality improvement. And so we kind of made a start nice and early, and got engaged with them. I got myself enrolled onto the program, and it basically involves you kind of go through the Institute of Healthcare Improvement certificate, basic certificate, as well as engaging in local workshops, teaching sessions, get some mentoring and guidance from experienced quality improvement people, and peer support across different projects. That was really useful, and really wanted to make sure, and this program helped to make sure that this kind of had a data focus, so that we could kind of have a feel for what constituted success in this project, and how would we show its value, both in terms of care but also in terms of money. So I came up with some aims for this project, and that was to minimise the amount of unnecessary time spent in ED and acute medical wards for palliative care patients. And it would involve the rapid assessment and senior decision making in order to provide rapid symptom control, safe discharge, future care planning, linking with primary care, community, specialist palliative care services. And we're going to collect some data around that, and then get some feedback from staff and service users. The project, I guess I started in posts in August 22. It was March 23 when we started kind of collecting, I started collecting data in earnest, and that was also around the same time as the SGM program started, so that was good timing. I had an idea of what data to collect before starting that, based on, as we've just been talking about, NACEL reports, particularly in terms of things like communication with patients and relatives and the importance of that, and achieving preferred places of death, and symptom control, anticipatory medicines, advanced care planning, those sorts of things. But also from knowledge of kind of trust priorities. So, our emergency departments are busier than ever. So trying to prevent people who don't need to come to the emergency department from returning to the emergency department, trying to improve the flow of patients through the hospital, whether that's getting them home or maybe to our hospice unit that's on the Antrim Hospital site here, or potentially reducing bed days, and other priorities within the department. So, and in order to know what those were, and again, this is where getting to grips with some of the QI methodology was really important. So, developing a driver diagram, and then this Pareto chart really helped me focus in on the priorities of the emergency and DAU departments in terms of what kind of were the low-hanging fruit, what were the barriers to getting specialist palliative care input in those departments from the people working in the departments themselves. And it's tiny text there, but big percentage here was just availability of service. Is there somebody around to do the work, and knowing how to access it? And once I started working, that felt like quite an easy thing to address. And then you're dealing with the biggest problems first, or you're focusing, where to focus your energy essentially. And yes, this has continued into, thankfully, the job became permanent, and this work is continuing, and we're trying to now build the service for the future. So how did we show benefit? Data is king. I suppose this is updated with data to kind of August 25. I do have more data than that, but I got too tired to keep going through my spreadsheets. But we've been able to see that 82% of the referrals are seen within 2 hours. 65% of patients either achieved their preferred place of death, which is usually home, or they died in a hospice, usually the Macmillan unit, and that for most people is a very acceptable second best if PPD is home. And it's hard to have to see data on, you know, what would the ED reattendances be for these patients if they hadn't seen me, I guess. But in terms of the patients that I have seen and followed then through until when they have died, 71% of them did not need to reattend ED, and 23% of them only reattended once. So that felt good. And actually that's 65%, sorry, of the patients who achieved preferred place of death. If you take out of that group of people, the ones who are clearly too sick to go anywhere except stay in the emergency department or stay in hospital because they are imminently dying, that number actually improves to about to 78%. And this is for the status for about 130 patients. Feedback from patients is often tricky to get, and that's definitely an area I want to try and improve on. But when you can get it, it's obviously very valuable, because these are the people we're trying to provide the service for. Of course, we also want to get feedback from our colleagues, and everybody felt it was important that the service continues and that there was access to specialist palliative care consultant for the hospital site. And also then some figures. Now, this was kind of 6-month figures. This is what I kind of took to the directors here and things back in, when was it? About November 23, probably. Some of these numbers are probably could be better in terms of, you know, more accurate for the Northern Trust or even for Northern Ireland generally. But it's basically just showing that if you can get figures together that try to show that you've saved money with the service, or that it at least doesn't cost a load of money, so that it feels worth it to the people holding the purse strings, then that is, I think, vital in terms of, particularly for something like a temporary service where you're trying to show that it should be continued and is worth spending money on. There are some challenges, of course, some which we already knew and some which we kind of discovered as we've gone. We're still waiting on our kind of regional advanced care planning strategy and the respect form rollout, and I suspect that's probably a big part of why England, Wales and Jersey have much better pre-hospital advanced care planning than we have here. And we know primary care is under immense pressure, and that's only increasing. Still rely a lot on other people to identify patients to refer to me. It's a definite challenge. And trying to roll out some education is how we're trying to address that. Access to medicines, particularly out of hours, controlled drugs for people to take home from the emergency department was a problem I hadn't thought about. That definitely exists. What do we do out of hours? Because as we've seen, our service only really exists 9 to 5, Monday to Friday. It only exists when I'm here. So if I'm on holiday, the service doesn't exist at the moment. And trying to get a bit more of that data about kind of those service users, which is a term I hate personally. So what are we thinking about doing about this? Well, we do plenty of lobbying, usually whinging to anybody who'll listen about our advanced care planning strategy, where it is and where's our respect forms. Primary care, if you can sort that one out, good luck to you, but it's a massive problem. We're trying to, so I have gotten myself embedded in the ED kind of education program, and that helps just highlight kind of how to identify patients and just being present and being open to people asking me questions. I'd love to get established some like ED champions, a couple of ED registrars that have an interest in end of life care and kind of have them teaching others, and that would also help with those out of hours periods. We're having ongoing discussions about pharmacy, but to be honest, it's not easy getting somebody home for the last hours of life in the middle of the night. Is it really a very comfortable thing to do? It happens very rarely where somebody's in the department at that time and needs to. So at the moment, we're just saying, well, if we can have everything ready so that first thing in the morning we can be ready to go home, then that feels like maybe that's actually okay. We're just working on that a little bit. What about when I'm on leave? Well, we've thanks to a mat leave that we couldn't fill with a consultant, we have a bit of extra specialty doctor cover, so we're trying to explore utilizing that in a similar role. And we also have access to a medical registrar for this year, junior registrar and IMT2 trainee that we're hoping to employ in the emergency department and DAU to see how that works. Obviously, that's a much less experienced person, and I think you do lose out when you lose some of that senior decision making in terms of making quick decisions. But we're going to try it out and see, and just trying to engage as much as possible with our service users. That's all I've got. There's obviously lots more I could talk about, and I'm happy if anybody wants to email me to ask for any further details. That was just kind of 10 minutes of an overview of how we went about things. And I see Connie's asked me a question.
I was just going to draw your attention to that.
PPD's home, secondary choice hospice, any discharge to care home, or patients discharging to our home from hospital for end of life care. Yeah, I mean it's nearly always preferable to hospital. I don't have numbers from this for you, although I could probably dig them out. But yeah, a care home kind of becomes home at that stage, where back into the community, but where home isn't an option because of care needs or whatever. So yeah, absolutely, nursing home, care home is a good place for people to die, for sure.
Thanks, Dan. Any questions? I think we still have a bit of time, have we, to take a few questions. And maybe if we go to Dan first, because we've just heard from him, and then we'll think about the recommendations. So any questions for Dan? Donna Louise, I see your hands up.
Thank you, Sally. Thanks, Dan, for a great presentation. I'm just curious, maybe thinking about the role of, I've put it in the chat as well, the advanced nurse practitioner role in ED. We had two brilliant district nurses who'd done their advanced nurse practitioner who were prescribing and had really made a difference in the community setting to palliative care access and support. Certainly, from in the Belfast area, it was great to hear from them. Would you see the role of having advanced nurse practitioners in an ED with palliative care prescribing?
Yeah, it's definitely an area that's worth exploring. I think there was an advanced nurse practitioner here, girl Helen McNeely, I think. She'll have to forgive me because I've forgotten, but she was an ED, advanced nurse practitioner who just had an interest in and she was a great ally to me in the department. I think it gets tricky, and Belfast Trust have I believe just recruited to a palliative care nurse specialist role within the emergency department. I'm very interested to see how they get on. I was actually speaking to Jenny yesterday, which is great. I think it's the tricky thing about that, and why we wanted, at least in the beginning, to have a consultant involved in this role is that kind of senior decision making is quite a key thing in terms of deciding that yes, I'm willing to take the risk of this person going home, or I'm willing to take the risk of this person going home with these medicines that might be new to them, and you kind of stand over that. And as well as, I guess, having the it's probably easier for me to get patients admitted directly to the Macmillan unit here than it would be for an advanced nurse practitioner, definitely, and probably for a CNS as well. It's just it's just the way it is, with these precious resources. So yes, I think it would be very helpful, and you certainly can't have an army of consultants in these roles, but I think that senior, you'd want them supported and protected a little bit as well. So yes, I can't wait to hear how Belfast get on. I think it's great
And
project.
I'm even thinking, Dan, somebody needs to decide that there's no reversible causes here, and that home or that bed is the right thing. So, and obviously, if somebody's sent to A&E, that medical assessment is key to that. But certainly, I look forward to the research that's going to happen within the Belfast Trust. I think they're putting 2 nurses in. So they are. So I think that will give us, and it is good to think about, how all of these professionals can complement each other. And obviously having the right professionals in the right place. But I think it's important then just to recognise, there's a level of responsibility with all of that sometimes can go beyond. It does have to sit with our consultants actually, and not even a specialist registrar.
Sometimes it's the ability to push back actually and say, no, actually this person does need to come into hospital, so let's stop trying to shove them out the door.
There's another hand up, Jean Maguire. Just if you want to go ahead, Jean.
Yeah, I just want to confirm that yes, we have 2 nurse specialists and with specialist palliative care and also prescribing, that is part of their role. And yes, Dan, we will be working and being in contact. I've already sent you a wee message there. So yeah, absolutely. But yeah, I agree with everything. It's exciting times ahead.
Yeah, Dan, really appreciate you coming along today. I don't see any other hands up at the minute for yourself, but I think it's really insightful, just as you've outlined there how you've used data from NACEL and other sources just to present the case and influence that. So thank you ever so much for sharing that with us today. And I didn't say at the outset, and I was supposed to say, the slides will be available and the recording will be available on the NACEL website after the meeting today. So just folks, then, in relation to the recommendations, and I'm conscious just of our time, but is there any quick questions for Joy Lynn? We'll probably just have a couple of minutes to take questions if there's any questions for Joy Lynn about the recommendations. Are we content to...
Sorry, Sally, I just closed that slideshow if that was still in use.
That's
I don't think I was supposed to.
Helen will sort us out, hopefully. So she will. So I don't see any hands up. So I think if we just move back to Heather then for next steps. Oh, sorry, Emma, you've your hand up again. Sorry. Nearly missed that one.
That's typical me, sorry. I'm just thinking of the recommendations and completely agree with all of them. I'm wondering as well from a regional perspective how recommendation 53 of the cancer strategy will impact on the communication side of things. We've seen a drop in that, drop in communication dealing with end of life. So it'll be just interesting to see if the work that Sharon McCloskey has been doing around advanced communication skills training and the level 2 that we're planning to develop in conjunction with hopefully CEC, I think, will impact on that. Just a comment, really.
Yeah, thanks, Emma. No, you're quite right. I think some of the work that Sharon's already engaged in, and many of ourselves are engaged in as well, will help that hopefully moving forward. So it might be one of the, not that any of the recommendations are easy, but one of the easier ones because there is something happening in that space at the moment. So if I don't see any other hands, I'll hand back over, Heather, to yourself then for the next steps. And then we'll go to Diane just for the closing remarks, if that's okay.
Thank you, Sally. Yeah, so I'll go through some next steps, and just to say, I hope it's been helpful to have this high-level overview of the NACEL Northern Ireland 24-25 findings and recommendations, and also to hear from Dr. Dan Suter about the palliative medicine at the front door QI project, and sort of how that can be applied to QI principles more broadly. So to continue on from this, we'd just really like to encourage you to take a look at the findings on the data and improvement tool, which I'll give a quick summary of shortly, to visit the NACEL portal QI pages, and to keep a lookout for the NACEL Northern Ireland outputs, which will be published in the coming weeks. So just on the data and improvement tool, so accessing the tool, you would need to register if you haven't already got access. And just to flag that accounts for the data and improvement tool are available for participating organisations. So if you're from other organisations such as hospices and you'd like some of the data, please take this to your locality boards to request that further insight. And so once you complete the registration form and then click the verification link that comes through, a notification comes through to the project lead for your organisation, who can then approve or decline the request. Now, once you've got access, we've got sort of 3 key sections, I suppose, within the data and improvement tool, each with a different level of detail. And so the most sort of summarised view that we have is this dashboard view. There's a dashboard for each of the 10 primary drivers. So if you're sort of looking at your data and you understand that there's one of those primary drivers is an area that you really want to improve on, you can then look at this dashboard and have everything sort of presented in a snapshot view, all available in one place. If you're then looking through and you've identified this area that you'd like to look into in more detail, you can then go into the overview section. And so these results are presented in the same sort of groupings, so how they map to the primary and then secondary drivers for NACEL. But you can see there as well, we've got these, the ability to compare the data. So you can select peer groups, which would be the Health and Social Care Trust and or acute and community. And that will produce this sort of third line along the bottom here. And we've also got filters, so you can look at the data split by whether it's a category 1 or category 2 death, by age grouping, ethnicity, whether the patient was reviewed by specialist palliative care or they had an individualised plan of care in place. You can look at the staff feedback group for the staff reported measure, and you can look at bereavement survey and case note review data split by a quarter of death. So if you're looking to really hone in on a specific time of the year or look at certain quarters, you can do that there. And then to go into even more detail, we then have these 2 explore views. So the first one is the bar option, which essentially is a way to really easily benchmark against other submissions for NACEL Northern Ireland. And you'll see here, so the pink bar is the selected submission. The blue bars are then the other submissions within the selected trust, and then the remaining bars are all other submissions. So that's a really nice way to see how you're comparing and where you sit in sort of terms of the wider picture. And we then have the time series view as well. So that is showing these work for the case note review and bereavement survey metrics. And you can then see results grouped by the date of death of the patient. So not when the data was received, but when the patient died, which will then allow sort of understanding of any changes over time. And if there is data collected in future, you can then sort of start building up an even sort of longer pattern and understand if there are dips or improvements at certain points in the year. And again, that's visible for the selected submission, for the region as a whole. And if you select a peer, you can also see that view there. So that is a really quick tour of the data and improvement tool. But if you've already accessed it and you've had a nosy round, the data on there now is final. We're just updating the dashboards as well to make those final, as they're sort of updated as a separate sort of element of the tool. But please do take a look, have a look around. If you have any questions, we have a guidance document, but also please do just get in touch with us and we'll be happy to help answer any questions. So then in terms of looking at the QI pages on the portal, so there's a lot of information in there. But if you've reviewed your data, you've reviewed the report, and you're now looking or wondering how you can use that data to inform QI work, have a look at the QI pages on the portal. There we've got the NACEL driver diagram, healthcare improvement plan, mapping documents, so you can understand how the questions we've asked relate to those primary drivers and the healthcare improvement goals. And we also then have suggested QI tools, some reporting templates, and we're just starting to gather a sort of community practice where we're really trying to encourage shared learning and shared knowledge. And these resources are intended to support you throughout the quality improvement process. So as Dan outlined earlier, knowing where to start and then what those steps are between starting and sort of making sure that project can then be sustained into the future. So hopefully these pages are a really helpful resource there of at least somewhere to get started. Then, of course, the report and other supporting outputs will be publishing those very soon. And so if you've been on the portal in the past, you may notice recently that the layout of it has all changed, but you can see here we've got the results and reports section, and then in there that drop down will be where you'll find the Northern Ireland outputs once they're published. We'll be sending those out to our contacts, so the project leads, deputy project leads, and other contacts we have. But if you don't receive that, or you can't find that email in your inbox, that's where you can go and you'll find them there. And now we talked a little bit earlier about the Good Practice Compendium for England, Wales and Jersey, and now that is based on the NACEL portal. And hopefully that will be a really great resource as well to take a look at all those different themes. But as part of the hospital site overview for Northern Ireland, we also collected these examples of good practice in Northern Ireland. So it's a document that will showcase examples of quality improvement work relating to palliative and end-of-life care. And we've just got a nice example there of something that was submitted by Western Health and Social Care Trust. So that will also be published alongside the report, infographic and other resources. And again, we've got that link there for the England, Wales and Jersey one if you want to look at their examples. And as Jonathan mentioned, if any of those stand out and you'd like to look at getting in contact with them, please let us know and we'll get in touch and ask that they ask if they're happy for you to get in touch with them. So that is sort of next steps and things to look out for. So I'll hand over to Diane now if anyone's got any questions, but otherwise I'll hand to Diane.
Just before we hand over to Diane, just to draw your attention just to the chat box, because there's a link there for the data improvement tool. And then Joylyn has very kindly then put a link, just if you have any questions in relation to that, you can make contact with them. So just to draw your attention to that, because I have been in the data improvement tool and it's great, but it does take a wee bit of practice just to navigate it. So it does. But once you go around it a few times, then you can navigate it much easier. But it's great to have that resource and that offer of help, just if we need it. So any questions just for Heather before we move to Diane? Everybody happy enough? Just okay. So we'll move over. Diane's going to give us the closing remarks then. Thanks, Diane.
Lovely, thank you, Sally, and thank you. So I get the nice part of today's job. So first of all, I want to say thank you to NHS Benchmarking, firstly for today's findings event, but for all the work that you've done over the audit over the past year. This is our 5th round of the audit. I've worked with Joylyn on all 5 of these rounds, and Heather more recently. And it's always fun working with them as well, and there's never a question that they won't answer for us. So thank you for that. I want to say thank you to Dan for his presentation today around the front door at Anton Mary Hospital. And I think it's a great example of how some of the data from NACEL has helped support an idea, which is then obviously starting to see results. And just to reiterate what Heather's already said about the good practice compendium for Northern Ireland, which will be released. There are other examples in there of great work, which we know you're all doing in your trust. And similarly, the England-Wales compendium as well. There's some great information in there. May give you some ideas of the things you could use. But mostly, I want to say thank you to all of you in the trusts. We appreciate and we know the effort that NACEL audit takes every year, particularly this year where it was a year-long effort. And we know initially the idea of doing NACEL this year was not fabulously received by everybody initially, but we were very keen to make sure that we did this audit on a year-long cycle and with the new improved data improvement tools so that you have that information. And it certainly gives us the most rich data set that we have to date around the quality of care of patients in our hospitals, both at a regional level, for you guys at a trust level, and individually at site level. So again, I would reiterate, do use those data improvement tools. As Sally said, it takes a little bit of time to get used to them. And as my husband will attest, you can disappear down a rabbit hole very, very quickly of an evening, but there's so much information to be used there. I think from the findings today, I think it's important that we celebrate some of the successes and improvements that we've made in Northern Ireland over the last number of years from NACEL. You know, we've seen there, we've made clear improvements in the offering and documenting of the nutrition options, still some work to do on hydration options, distinct improvements which have been recommendations before around anticipatory prescribing, which is consistently high now. We've seen improvements with regards to the needs of those important to the person with regards to the emotional and psychological and the social and practical needs. Still, as the findings, the recommendations highlight some work to be done around the spiritual and religious and cultural needs of those patients. And we've also seen clear improvement in the access to 24/7 advice across the region. And I think it's important to note that one of the submissions to the trust who does not currently have that is a choice by that trust, that should be 100. We have very clear things to do with regards to the 7-day working, which we know within Northern Ireland, and work that Sally is progressing under the Palliative Care and Partnership Programme is hoping to start to look at that piece. I suppose from the finding as well, there's some things we've looked at regionally which we're curious about understanding a little bit better. The reduction in category 1 deaths, those who are expected to die, we've seen a reduction in that, 78% this year compared to, I think it was 93% in 22-23. And we've seen as well that increase in the length of time that patients are in hospital before they're recognised as dying. So that's increased from 72 hours in 22-23 to 139 hours. So we would be interested in understanding maybe a little bit about why our clinicians think that will. I think potentially some of that has to do with what happens before they enter the hospital in the community, but I think that's a conversation we need to be looking at. The other thing that's an interesting statistic, which wasn't presented today but will be in the report, is the increase in patients who are being seen by the specialist palliative care teams. And there's a couple of theories around about why that might be. So that's a discussion we'd like to have. We've talked a little bit about the decline and the need for mandatory and priority education and training, and how that links with the work of our Palliative Care and Partnership Priority 3 and that education and learning steering group. So we will certainly be progressing that. With regards to what's next, say regionally, we will be looking to explore some of those questions with our forums within the Palliative Care and Partnership Programme Board, our clinical engagement group, and hopefully at your locality board levels to start some of those discussions. If I can just encourage you all at trust levels to please do use the data that you have, compare it with your peers. It's the first time you've been able to do that. digitally, look at it, look at your individual sites to see if one site is performing better than the others, etc., and what learning you can use locally. The Palliative Care and Partnership Programme co-chairs will be in touch with trusts with regards to getting your NACEL action plans updated, and then watching the implementation of those over the coming months. And I suppose the last bit is just the good news, which has been referred to, that there will be no NACEL audit in Northern Ireland in 2026. We heard very clearly from yourselves that there was some time needed to implement some of the changes and the recommendations. So that will be granted to you, and the next conversation that we will be having with NACEL with regards to running the audit again will be for the 2027 audit, and we will keep in touch with them around that. So just thank you to everybody for all the work that you do in this area, for all the improvements we know that you are making, for the difference that you are making to the patients who are in your care in hospitals in the last day of life. And thank you to the NHS benchmarking team. And I'm going to miss our meetings in 2026. I'm thoroughly looking forward to restarting them again in 2027. So thank you, everybody.
Thank you, everybody. Take care.
Bye-bye. Great, thank you. Have a nice day, everyone.
Thank you.
Thanks.
Thanks, mate.
Thank you.